Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy World, Healthy Nation, Healthy You. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today we are continuing on our venture into autism. In our series on autism, we are really looking at this issue from many different perspectives. And today we have a wonderful opportunity to meet a scientist who is an epidemiologist, the study of epidemics. And this individual, who I will introduce in a moment, has a tremendous background to share with us today. And we are going to attempt to answer a very difficult question, and that is, autism, is it indeed an epidemic? And to that point, I'd like to introduce our guest, Dr. Jennifer Pinto-Martin. And Jennifer comes to us today from the University of Pennsylvania School of Nursing, where she is a professor and chair of the Department of Biobehavioral Health Sciences at Penn. And she also has an appointment as the director of the Center for Disease Control Center for the Study of Autism and Developmental Disabilities Research and Epidemiology. Now that's a mouthful, but we're going to be defining these terms so that you will, after listening to this show, really have a very good handle on what this means and how you can use this knowledge for yourself and for others. This Center for Disease Control funded research center is really an important point, and she will be talking about her work and her science and her research and the research that others at this center are doing. This center is unique at the School of Nursing because there are 6 such centers in the United States, but this is the only one at a School of Nursing. And the University of Pennsylvania is a great place for this center to be housed. The others, for those of you who are listening and would like to know more about these centers and follow up, are located in Atlanta, the University of North Carolina, Kaiser Permanente in California, the University of Colorado, and Johns Hopkins University. So each of these centers is for the study of autism, and we are very happy that there are these funded centers out there to really help us get to the point that we're going to be discussing today, and that is this an epidemic? So I want to thank you, Jennifer, for being with us today. We're really, really fortunate to have you as a scientist and a scholar really spending some time with us.
Thank you, Nancy. I'm happy to be here.
Thanks so much. Well, let's start with this first question because obviously we're hearing more and more about autism. And we've heard that it is really, a function of awareness and that we're really expanding the diagnostic criteria, which you'll have to explain to us what that even means. But is that really true? Is that really where we're going with this disorder?
So I get often asked, is this an epidemic? And I think to answer that question, we really need to understand how autism is diagnosed and how that has changed over the past 2 decades, really. You have to remember that there's no blood test for autism. It's a behaviorally based assessment that's done by a trained clinician. And what happens over time is that the umbrella that captures autism has broadened. Mm-hmm. So in the past, someone with autism was very severely affected, had no language. Anybody walking in the room probably would recognize that as someone with autism. These days, we include a spectrum under that umbrella, and it includes much milder cases of autism spectrum disorder. And those individuals get the label and therefore increase the prevalence, the number of people who carry the label in any given city, any given state, and in the whole country. So the Center for Disease Control understands that, how the change in the diagnosis can inflate the numbers that carry the label, and they established these centers in part to help understand how that change in diagnosis is influencing the prevalence, which is what we describe when we put numbers out. So the most recent numbers from the CDC centers talk about 1 in 68.
Right.
So 1 in every 68 8-year-olds, because that's the population we're studying most carefully, carries an autism spectrum disorder diagnosis. Now that is much, much higher than what we knew 10 years ago or 20 years ago when we were talking about in the 10,000s, 1 per 10,000. So people say, well, it must be an epidemic. But the fact is, we don't know whether it's an epidemic because we don't know what causes it.
Right.
So for something to be an epidemic, we have to say there's an increase in the risk of getting that disease because such and such has happened, or this exposure is occurring. Because we don't know what causes autism, we can't point to that.
Right.
What we can say definitively is many more children are out there who have the label of autism spectrum disorder, and those children and their families need services and support, both educationally and medically.
Right. Well, let's go back, because you really gave us a great introduction into this by just what you said. But when you said it was behaviorally diagnosed, tell people what behaviorally diagnosed really means.
So in order to get a diagnosis of autism, the child comes in, it's typically a child comes in and meets with a clinician and sits at a table much like this with a clinician, and the clinician takes out a suitcase. And it's a toolkit that is actually a diagnostic toolkit. And it's a series of interactions and games that the clinician plays with the child to gauge 3 things: to gauge communication ability,
Right.
to gauge social interaction, and to gauge interest, restrictive interest, repetitive behavior. So those are the 3 domains that are part of the diagnosis of autism. In order to get the diagnosis, you have to have deficits in all 3 of those domains.
Okay, so give us an example. If someone was looking at this kid, tell us the first domain and what they would see.
So one of the domains is social interaction, as I mentioned. So a very good way to test that in a young child, and these children are typically young, between the ages of 2 and 5, is to set up a pretend play situation. So I have a baby doll here and it's the baby's birthday. Let's have a birthday party. Any 18-month-old or 2-year-old will jump right in there and say, have some cake and happy birthday, and we'll feed the doll and we'll engage in an interaction that includes you and the pretend play, because that's so important to child's development. They need to understand how to engage, how to draw someone in. It just happens without any effort at all.
Right.
A child with autism will not engage in that kind of social interaction. They may take the cake and turn it upside down and spin it around. They may bang on the table, but they're not engaging you in this social interaction.
So essentially, they don't see the association between the event and their role in that.
That's right, and they're not interested in engaging you in what they're doing. They're very interested in playing by themselves, typically in a very routine way. They will line things up. They will put them in color order or in size order. Lining up is a big one. And if you try and join in, and maybe it's a set of cars, you try and join in and take one of the cars, it's very upsetting. Because that's not what they're looking for. They're looking for order and consistency.
Okay.
So it's a very different kind of play and engagement, and once you've seen it a few times, it's very, very obvious. There's a really wonderful set of video clips that I recommend to everyone that's online now, where you see a typically developing child in one clip and then a child with autism in the other clip. And the difference in these kinds of behaviors is so obvious when you see it side by side.
Well, maybe you can share that with us and we'll put it on the website so people will have an opportunity to access that.
Sure,
because
I think it's great for parents.
Because you're really helping parents to be better observers.
Exactly, so that they can then go to a pediatrician and say, I've seen this behavior in my child, I'm a little worried about it, I saw it online, and can you help me understand if there's a risk here? I think that's very important.
That's great. So give us the second category and how this assessment would work.
So communication. So parents who have children with autism often come in to their doctor and say, I think my child doesn't hear well. I think my child is deaf. Because they'll walk into a room and they'll call the child's name, Nancy, and the child won't turn around, won't look at them, won't respond. And so you would think they're not hearing correctly. It turns out their hearing is just fine, but again, it's that sense of not wanting to communicate, not wanting, sort of shutting the world out, if you will. So again, there's communication strategies in this diagnostic assessment that requires the child to respond appropriately, and they don't. They don't necessarily look. If I say, look, A typical child will look right away
Right.
and then look back
Right.
at you. That kind of interaction is not seen.
Right.
So
that's pretty dramatic. And
Yes.
the third would be what?
the third is this restrictive and repetitive interest, and again, we can gauge that, we can see that emerge as we have them play with these various toys, because they're not playing with them appropriately. They're playing with them in a very routine way. They tend to take a car, for example, and spin the wheel of the car over and over again. They're not playing with
Right.
it like a car, they're interested in that wheel. So we see things like this over and over again, and parents will say, yes, I see that in my child, yes, I see that in my child. They can confirm that they see this at home.
Right.
They can also, we also interview the parent, and we can ask about the child's response to, for example, a change in routine. We're not going to drive to school the same way today because there's a construction. That can be very upsetting to a child with autism and can set off a tantrum. So these kinds of reactions to the world around
Right.
us are very different.
Right. I think Jennifer has really given us a very, very clear idea of how these diagnostic tests work. And you can really observe these behaviors long before you even get to the diagnostic tests. And I think that's really part of what she's trying to help you do. And that is by giving these examples, you can say, I know a child in the neighborhood, I think it's my own child. Or if you're a grandparent, you may have suspicions about your grandchild, and you can then take that next step to really have it done professionally. But these things are very simple, very concrete, things that you can see as you're spending any time at all with a child that has these problems. But I was intrigued with what you said earlier, because I remember when I was even in training for nursing, I worked at a Eastern State School and Hospital in Pennsylvania. There were children that were very profoundly autistic and really had those behaviors right off the charts. But how did it go from people who were severe, like you said, even if people didn't have the label, they didn't know that this is autism, seeing a child like that, they would say, there's something wrong with this child. But how did it go to people that had less dramatic? And where was that sort of change point?
So it's a really good question, Nancy. I think part of the change comes from understanding that for mildly affected children, early intervention can make a difference. So it's better to label a child than to not label a child. It used to be that people were afraid of the label and they didn't want to pursue it. Now we recognize if your child has impairments in those 3 domains, but they're mild, we can work with that child and really help overcome them. We can't cure autism, but we can do behavioral interventions that will help the child get into mainstream school and really live a life that is not burdened by their disease. So I think understanding that there are milder components of this disorder helped us to push for labeling those milder cases, because we knew we could do something about it.
Right.
The profoundly affected children, unfortunately, there's not much that can be done behaviorally or with psychopharmacology. We don't have an answer. So the other thing that happened is that many children with autism also have mental retardation. In fact, about 40% of autism have what we call comorbid, coexisting mental retardation. And in the past, they would receive the label of mental retardation, and no one would look further to say, do they also have autism? It wasn't relevant. They had a label. They were in special education. We now realize it's very important to look in those children, because there are interventions that we can do that will help that child be more successful in their life.
Right.
And so we push for that label. We seek that diagnostic evaluation that will then label that child as autism. Again, that's something that's going to increase the prevalence, right? The number of people who carry the label, because we're labeling children and in the past wouldn't have ever received that label.
I think Jennifer's given us really 2 very important tips in what she just told us. One is that if you have a child or know of a child that really is not exhibiting the profound changes in their behavior, but even mild forms where they're lining things up a lot, they're playing alone a lot. Sometimes they'll pay attention to you, many times they won't, but that's different than adolescence. I mean, we know what that's all about. But you know in your gut when this thing is not looking quite right to you. Better to go and have that taken care of by really getting that assessment and diagnosis. I think the second tip, as she talked about, is that when you really think about scary labels, you know, when any disease has got a scary label, it's usually related to not knowing a lot about what this is all about. What is fearful is the unknown. But what I think she's really helping us to interpret is that this label is really a very positive next step, because it is the ticket to really getting that child the services that they need. And because because of these centers that Jennifer is heading up at the University of Pennsylvania School of Nursing, we're learning so much more. So in that learning, we have so much more to offer you. So this time, labels are good. So tell us more about how then that changed this whole idea of this being an epidemic. Suddenly, this label became really an important vehicle to really help children get services. So people that had many milder symptoms of this then could be categorized. And I understand that there are categories of mild, moderate, and severe. Is that correct?
That's right, in all of those domains. Now, the criteria are changing yet again, but I think the areas of impairment will remain the same. And I think the other important thing to think about when we think of the larger umbrella and more children under that umbrella is that it's brought funding to the table in a way that would not have been possible otherwise, to then really look at what is the cause. So these centers that you described are also involved collectively in a large, what we call epidemiologic study. So that's a population-based study to understand the risk factors for autism. Because only if we understand the risk factors can we do things that might prevent the disease down the line, the disorder down the line. So we are all collecting data, and we will pool our data together, and we believe we will be able to uncover some of those risk factors that may be able to be intervened upon, if you will, that will actually be able to reduce the risk of the disease by understanding what causes it.
Well, that's very hopeful. I mean, the fact that you've been funded since 2001 and that all these centers, even though they're in these 6 different locations, are linked together in terms of the science of really having these studies. When she says pool the data, all the people that are being studied in any one place are really mixed together, and that way it gives you a bigger sample size, and therefore anything you learn has more power in terms of it being really true and correct. So I think that let's go to our next point of this, because I really think that so many people feel that maybe children are born with this, meaning that it is there's a genetic component, and that really that is what's driving this. But there are other people that feel that it's environmental, and that can be a broad spectrum of environmental issues. So what are your opinions and your thoughts on that, since you're studying this every day?
So that's a great question, and that's exactly what our study is designed to address. We know it's a genetic disorder because we see that it runs in families. If you have one child who's on the autism spectrum, your chances of having another child on the autism spectrum are 10 times greater than what we see in the general population.
That's high.
So that's very high. So the other group that we can study that give us a lot of information are twins. So twins, identical twins, have the same DNA. Right? So if it was, that's the genetic code that helps us be who we are. If it was a purely genetic disorder, you would expect if one twin has autism, the other twin would have autism if they're identical twins.
Right.
What we see is that they are what we call concordant, have the same disorder about 60 or 70% of the time, but not 100% of the time.
That's interesting. Now, what do you think would make that difference?
So what we know is that's what we call a gene-environment interaction. So the genetics matter, but there has to be an environmental trigger that's operating on that genetic structure to actually trigger the autism.
Now, we don't know if that environmental is in utero, meaning before the babies are born, or if it's something that happens after they're born.
That's right, and that's exactly what the study to explore early development, which is this big epidemiologic study that I was talking about, is designed to do. So we're collecting data from the mother, we're collecting data from her pregnancy history, from her labor and delivery record, and we're looking at all of these different time points. What we do know from other investigators who've done very sophisticated work now on the brains of children with autism is that their brains are different. Their brains are different, they grow differently in utero, they have different areas that are bigger and smaller, the neuronal connections, the little synapses that are in our brain that fire and that help us think are different. So we believe now that there are things happening in utero that predispose a child to autism.
Right.
That helps us narrow the focus for causal agents, we believe that the most important period is during that gestational period. It may not be the only important period, but we know that that period matters.
Right.
So that's a very important finding.
Now, because we really don't know, I'm just sort of curious about maternal guilt. A lot of moms feel like they must have done something wrong and it's their fault. I mean, how does this get addressed?
So it's an interesting question because the science of autism spectrum disorders has a sort of ugly history, I will say. There was a hypothesis that existed called the refrigerator mother hypothesis. Maybe some of the guests listening to the show have heard of it. The notion was that autism was caused by a mother who wasn't warm and welcoming and loving to her child. She was refrigerator. She closed the child out. Now you can imagine how a hypothesis like that might have emerged if you have a child that isn't very socially interactive.
Right.
The child isn't necessarily going to respond every time that you talk to them. They don't necessarily want to be held and cuddled. So someone observing that mother-child pair might say, there's not warmth and love there. It must be that's what's causing the child's autism. It was an incredibly damaging hypothesis, very guilt-producing, as you can imagine, and absolutely wrong.
And not based on science.
Not based on science, based on an observation of an interaction. So what we know now is that autism is not one cause, that there are genetic factors that in some cases have nothing to do with the mother. I'll tell you about one of those in a second. And that what we need to do is understand what the environmental factors are that we can have some control over. One of the factors that has been now consistently reported in the literature is father's age. So older fathers have an increased risk of having a child on the autism spectrum.
And what's older? What's
so
the age?
The risk starts to climb after age 37, believe it or not, but then it gets higher and higher. And it used to be that many genetic disorders were blamed on older mothers. They said old eggs were a bad thing, and these disorders occurred as a result. In a complex psychiatric disorder like autism, we now know that the father's contribution is actually the more important one. And it's because the father's genetic material, the father's sperm, regenerates every 15 days, and there's opportunity for error. The more you copy something, the more chance there is for an error, and that's really what's going on here. So it's actually father's age that is the greater risk. Now, older fathers will marry older mothers, but the risk resides in the father's age. So that's something that we know. That's something we can counsel families about. We can't prevent older fathers from having children, and certainly not every older father will have a child on the autism spectrum. But knowing that that risk climbs with age is something that people can interpret and do with what they will.
Right. So if someone did have a child with autism, would you be recommending that they get further genetic testing?
No, and that's a very good question. Now, not everyone would agree with me, but we don't have a gene for autism right now. So some families are getting counseled to get these genetic screens to look for these variations in the copying that I talked about. They're called copy number variations in genetic terminology. But they're not predictive. We don't know what it means. We know that there are a lot of them out there, but it's not going to help that individual family. Right now, insurance won't pay for it because there's no treatment associated with it. As part of a research study, I think it's very important to gather genetic information, but for a family to pay for that information is not going to necessarily help that family. It's a mutation that happened within that pregnancy. It's not going to predict anything for a later pregnancy. So.
I'd just like to underscore what Jennifer just said to us, because I know there are a lot of people watching this who do have a lot of guilt. And just because, again, we don't know what this is all about, guilt gets in the way. And the more guilt that you have and the more that you feel like somehow you caused this really doesn't help the situation, certainly doesn't help you as the parent. So I think that since we don't know, but we're still investigating, all you can do is be as healthy as you can in your pregnancy, be as optimistic that you're going to have healthy children like any parent going into parenthood really wants to be, and really understand your family history, etc. But other than that, it really isn't about anything that you did wrong. I mean, once maybe other factors are uncovered in time, we will have a better idea. But I think that if you get nothing out of this show, know that it wasn't your fault, because we don't know that there's anything that you could have done differently, and maybe we'll find out more about that and we'll have better tools in the future to help people. Let's really finish with what your work does to really help inform people about getting services.
So there are a couple different things. One of the things that we've pushed for very hard at the University of Pennsylvania is early ascertainment, early diagnosis, early recognition. We know that the mean age of diagnosis, the mean age when children are labeled with autism spectrum disorders is about 4.5 years right now across the nation. That's very, very late. We can recognize it, a clinician can certainly recognize it between 18 months and 2 years. We can do the evaluation between 18 months and 2 years. We shouldn't be waiting until age 4. And that means that parents have to be proactive. They have to learn the signs. The CDC campaign is learn the signs, act early. And that's for a reason. The earlier that child is evaluated and diagnosed, the earlier that child can get services. The brain is very malleable. It's very able to be molded early in life. And so if you can have that label and have the child in intensive services early on, it can make a big difference. So I think that's a very important thing that we're pushing. We're trying to get routine screening for autism as part of pediatric primary care visits. So just the way we screen for vision problems or hearing problems, we would be screening for autism across the board, so that it wouldn't be a question of a family having to bring the child forward and say, please look. It would be routine.
That would
just be doing it.
That would be a breakthrough. Is that going to be costly? Because I think that's the first thing people will say. Is that going to cost me money individually, or is it going to cost the insurance world more money?
So it's a great question. If it's part of routine pediatric care, it won't cost the patient any more money, and it doesn't take very long. There is a very short screening questionnaire that is quite strong, quite good at picking up children who are at risk. It may capture more children than ultimately get the label, but that's what we want a screening tool to do. We want it to capture everybody who may be at risk, and then we'll do another level of evaluation to find out those who really do have the disorder. So it works, it doesn't take very long, and we're really starting to see pediatric practices pick it up.
That's very encouraging, because then it's really a sort of a no-brainer, so to speak, and that you don't have to really necessarily be always the initiator of this. You have a partner in your care provider, whether it's a nurse practitioner or a pediatrician, whoever it may be. You need that partnership. It really helps everyone. So I guess in closing, the answer to the question, autism spectrum disorder, is it indeed an epidemic, is not an easy yes or no answer.
That's right. I wish it was. I think that the jury is still out, we'll say. We have data that's coming in every single day that will help us understand what those causal factors are, and that will help us at the end of the day determine whether it's an epidemic. I think at the end of the day, it doesn't really matter. What matters is that we need to get those children identified and in services as early as possible, and we need to support the families and the children who are carrying the label today.
Right. Well, I just want to thank our guest, Jennifer Pinto-Martin, for being with us today, because you as a scientist and an investigator is really behind the scenes in terms of day-to-day life with this particular problem. But this is so important, because this work that's being done behind the scenes is very much going to influence clinicians, all the physicians, the practices, the nurses, you as parents, you as teachers. Anyone that's listening to this show is probably going to know a child that is somewhere on this spectrum. You can play a very pivotal role, because your knowledge base and your awareness will really help you to be kinder, gentler, more understanding, and help people to get this diagnosis early. So we've learned through many of these discussions that autism and that label can really be very helpful. It's the first step, like in any disorder, whether it's heart disease or cancer or any other problem. Until you have that understanding of what it is that's wrong, can you really then take those next steps to really address it, and address it in a very positive way. So I want to thank Jennifer again for being our sparkling guest. I want to thank each of you for spending the time with us today and listening. I hope that this knowledge will help you and others that you interact with. So remember, with health, all things are possible. Have a wonderful day. I hope you enjoyed our conversation today, and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening and join us again. And remember, with health, all things are possible.